You can start, Dr. Mehta.
Good evening and welcome to Spine Time. My name is Neel Mehta and I'll be your host tonight. And today we will be talking about ambulatory spine surgery, the ins and outs of same-day procedures. Spine Time is our featured YouTube presentation discussing various topics about spine care here through Weill Cornell Medicine Center for Comprehensive Spine Care and at NewYork-Presbyterian Hospital. I want to remind people that all of the past Spine Time programs are available on our YouTube site. And also, any questions that you may have during the presentation, please use the chat box and we will try to address the questions as we get through the program. If we're not able to get to your question, we certainly apologize in advance. And we encourage everyone to schedule appointments with one of the spine providers here in the center on 59th and 2nd. I'm joined today by my colleagues, Dr. Roger Hartl, who's professor of neurosurgery and chief of spinal surgery here, and director of neurosurgery's Center for Comprehensive Spine Care. And he and I have worked together for many years, and we've been together on Spine Time a number of times in the past. And then also with one of my new colleagues, Dr. Lynn McGrath. He's an assistant professor of neurosurgery and performs and treats patients at NewYork-Presbyterian, Queens. So please allow a warm welcome for my two colleagues here.
Thanks, Neel.
And we're going to talk a little bit about same-day surgery. And I guess we've sort of defined that here on our slide, but Lynn, tell me, what do you think? What do you counsel patients on the goal for same-day surgery?
Thanks, Neel, and thanks for the nice introduction. The thing that I tell patients is that what they have heard from friends or family members that have had spine surgery in the past is not necessarily true these days. And a lot of the surgeries that used to require a hospitalization, even an extended hospitalization, are able to be done now using a same-day surgery. So that means that you arrive to the hospital in the morning, you go home after the surgery, after you've woken up and you've recovered, and the whole thing takes place in one day. You don't spend any time in the hospital. This can happen actually either in a hospital or in an ambulatory surgery center, which are becoming more and more common these days.
What's the difference between a hospital and a surgery center? And what is the preferred way to go?
Well, that's a matter of debate right now, actually. There are some advantages to doing things in an ambulatory surgery center. Usually it's cheaper for insurance. It's a little bit more convenient in terms of the logistics for a patient. You can park right out in front, get your surgery. It's very customer service oriented. You go home the same day. In a hospital setting, there's a little bit more resources at the surgeon's disposal. Usually, they have the whole complement of tools that you'd have in a hospital setting. And in the rare event that a surgery that was planned to occur in one day requires an inpatient admission overnight, that's a lot less inconvenient in the hospital setting. So currently, we're doing outpatient surgeries, ambulatory surgeries, where we're sending patients home the day of the surgery, but we're doing all of that in a hospital setting.
And Roger, tell me how this has evolved over time. I mean, are you guys doing more invasive things, or are you doing more types of procedures in this sort of same-day component?
Yeah, Neel, first of all, thanks for having me, and thanks, Lynn, for kind of exposing the audience to and explaining really what ambulatory surgery is. And some people call it same-day surgery, ambulatory surgery. It's closely associated, obviously, with minimally invasive surgery, because the whole idea is to do this safely, do this efficiently and effectively. And I think historically, it's really, what happened is that obviously all of these procedures were done in the hospital. As the procedures were refined over the last 10, 20 years, where surgeons realized that this could be done some of the operations can be done in a relatively short time period, and there's very little blood loss. Patients repeatedly did very, very well. They realized that, there's no real need for those patients to stay in the hospital overnight. Keep in mind that, like, for example, in a place like Europe, it's very difficult to do this because insurance carriers and the whole hospital system is set up in a way that patients are encouraged to stay in the hospital overnight. So the whole concept of ambulatory or same-day surgery is really a little bit more maybe an American phenomenon than a worldwide phenomenon. But we've just seen over the years that this can be done very safely, frequently, and these patients can be sent home the same day. And therefore, if you have the facility, if you have the setup, as Lynn mentioned, it can be a very, very easy experience for the patient. In my opinion, the number one priority has to be safe, right? And we do a lot of ambulatory surgery, as Lynn mentioned. Right now, we do it in the hospital setting. We have an ambulatory surgery center on York Avenue, which is DHK, and we're currently setting ourselves up to do more spine procedures there. Neel, you guys already are doing, injections and so forth there, but for spinal surgeries that require general anesthesia, we're setting up DHK to move into DHK with some of our procedures. But most of it we're still doing in the main hospital. But those patients also go home the same day.
Sorry about that. And certainly that makes sense. I mean, that's where we're heading with many types of surgeries, and it seems like spine is perfect for this. Let's talk a little bit about the results here. So walk me through this, Lynn. What are we looking at in terms of how things have evolved?
I think the keys are that there are new technologies and new techniques that allow us to do things in a much more precise and a less invasive way. So all of those things combine to create less complicated patient experience, a shorter recovery time. By making a smaller incision, we damage less of the soft tissues, we lose less blood. That leads to lower complication rates. I'm just going around the circle here. Less scarring, less postoperative pain. All those conspire to give the patient a quicker recovery, less time in the hospital, and a faster return to normal activities of daily life, whether that's going back to work, whether that's going back to taking care of your kids, or whether that's going back to, just puttering around the house. Whatever your goals are, the new techniques and technologies that we're using allow you to get back to doing that quicker.
So, Roger, walk me through this in terms of, as you've seen these things evolve, what was it 10 years ago in terms of what you would guide or recommend to a patient in terms of expecting for time of recovery versus today?
Neel, I noticed that you asked me all these historical questions, and I don't know why am I the one who has to answer all these questions that make me look old, but I'm happy to do it. So 10 years ago, I can tell you the experience at Cornell was that, we started doing minimally invasive surgery, about 15 years ago probably. And it became just evident that a lot of these patients, a patient who had a lumbar laminectomy, for example, which nowadays we do minimally invasive, those patients used to stay in the hospital sometimes 2 or 3 nights. And same with, even some of the simple fusion cases that we do now where patients go home the next day. We're discussing now, why not? There's no reason why a lot of these, if they're young, healthy, and they have, a lot of it has to do with expectations. If you talk to patients about this, there's no reason why some of these patients, even with a fusion operation, shouldn't be able to go home the same day if everything goes perfectly well. And it goes perfectly well because we do this all the time. That's the other thing. There has to be a volume, right? If you do like a particular operation 3 times a year, you're never going to get to the point where you can send patients home the same day because you just don't really get good at it. But a lot of these types of procedures now and I can see it with Lynn and with the other guys, surgeons, we do this over and over, and that's how we get good at it, and that's how we get these patients out the same day. So 10 years ago at Cornell, a lumbar laminectomy would stay in the hospital 2 or 3 days, and then we were watching our recovery times for patients, and we just noticed that these patients really could go home earlier. And then at some point we made that decision, maybe about 7-8 years ago, that we said, well, let's send them home the same day, and it's just worked. But I think what's also important is to really ask patients, what are their expectations? I'm just wondering, maybe some patients, don't necessarily want to go home the same day. And I have that also. I have patients who say, well, we really want to stay one night in the hospital. Now with COVID, that's not so frequent, but it comes up. So actually that would be my question to you and to Lynn, and maybe even to the audience. What are your thoughts about, going home the same day? I'm just wondering if that's something that's desirable for everybody, or if some patients maybe in the audience have any comments about that.
Yeah, I think we had a poll that I wanted to actually get to. I guess, where is that?
I think.
Dr. Mehta, do you want me to launch it?
Oh yeah, that would be great.
Okay.
So here's a poll. We really wanted to get your preferences out and see if we're on the same page. So if you could take a moment to answer these 2 questions regarding what your preference would be and also what your concerns may be. And Lynn will sing the songs to go along in the background music.
No one on this call wants to hear me sing. Dr. Hartl's got a better voice.
So if you had a spinal operation that involved general anesthesia, which would you prefer? Go home the same day, stay in the hospital at least one night, or you're not sure? You just got to click on whatever you think is the appropriate answer.
And looks like we're finding a trend here. We'll give this. Okay, great, thank you. So for question number 1, if you had a spinal operation, which would you prefer? And it sounds like stay in the hospital at least one night is the winner. So that's an interesting thing. And what would be the concern about same-day surgery is complications was number 1, and mobility and ability to get around. So I guess let's talk about that. How do you recognize a complication, and what are the things that you counsel patients that if they do go home to be aware of? And what confidence, I guess, can they have in that they would recognize a complication early enough? I open it to either one of you.
That's great. I think the way to counsel patients is to look at the data and explain it to them. And one of the things that we can point to is that lots of literature has shown that there is no increase in complications doing things minimally invasively or on an outpatient basis, as opposed to doing things on an inpatient basis, staying a night or 2. But ultimately what it comes down to is what the patient is comfortable with. So we can offer these things and we can have these capabilities, and we can assure the patients that it's a safe thing to do. It's been very well studied. But ultimately, the patient has to be comfortable with what's going on. And so I think one of the reasons why we continue to do things in an outpatient center is because it gives us the option to always keep someone for a night if they're just not feeling ready to go home after surgery. If their family is not comfortable taking care of them, we always have that option. But I think increasingly people seem a little bit hesitant in the office when we talk about giving them the option of going home the same day. And then when they wake up from surgery, they're feeling really good, better than they probably expected. And a lot of patients seem to make the decision after surgery to go home, even though they might have been on the fence ahead of time.
So a couple of things that are coming up in the chat seem to be less to do with the surgery, but more of the social situation. Who's there to help? And what kind of help would someone need after surgery? I mean, how mobile should they expect to be if they go home the same day?
Yeah, those are really good points. And so I always try to make a point, obviously, to ask, and if not me, then certainly Rebecca, who works with me mostly, who's at home when you go home? If somebody doesn't have anybody at home, we're not going to send them home after surgery the same day. Sometimes you have to talk about if they don't have anybody and they have a big operation, they may have to go to rehab even, which is also a possibility. And that's sometimes a little bit difficult to set up before surgery. And we're kind of struggling with that a little bit because that requires insurance approval. You can't get that before surgery. So the patient has to be in the hospital for us to really request a rehab spot for a patient. So that's a little bit more complicated. If somebody lives more than 2 or 3 hours away, then we usually keep them here. We don't let them drive, even as a passenger, of course. We don't let them drive home that long time period, So you a lot of it has to do with planning, as you mentioned. So you really have to understand the social situation of that patient.
Well, certainly by law, we're not allowed to let someone who's had anesthesia go home on their own. In terms of pain control, I guess, what are you guys doing that's novel in surgery itself that would allow a patient to be relatively comfortable, going home?
Yeah, I maybe I get started. Let Lynn then comment also. We implemented a protocol, the ARAS protocol, ERAS, and what that really tries to do is try to optimize, or maybe Neel, you probably know better since you're really by training an anesthesiologist. So
right.
So I'll only mention ARAS, and you'll tell us exactly what that means. But that has really helped us tremendously to facilitate, less invasive and ambulatory surgery. And just as one side note, as a consequence of implementing that protocol, we have data, and I think Michael Verk, who's one of our partners, and together with your team, is about to publish that you can reduce the need of opioids after surgery dramatically, just due to that protocol that we implemented. And maybe you want to say a few words about what that protocol entails.
So ERAS, ERAS stands for Enhanced Recovery from Ambulatory Surgery. So again, the same topic we're talking about, and it doesn't just apply to spine, it applies basically to any surgery. And the thought is everything that we do sort of before surgery, during surgery, and even afterwards can change the outcome. And that includes pain control, how much IV fluids, when to resume eating. A lot of these things are looked at broadly. And yes, Dr. Verk and Dr. Joshi, my colleague, have done some tremendous work looking at how much we were able to really reduce and expose people to opioids and mitigate risk on all the complications of opioids by implementing these protocols. So that's been really, really exciting to see. But I think this gets back to what do you tell people in terms of return to work or return to activities? When has that clearance time period changed and improved over as these things have evolved?
You let Lynn answer.
Well, I mean, you're asking.
Dr. Hartl, I've only ever had the minimally invasive toolkit, so I never had to counsel patients about what to expect after doing things the old way.
He wasn't a barbarian, is what he's trying to tell you.
Well, it depends on the work. A lot of it has to do with the commute. Now that people work from home, I have people log on to meetings like within a day after surgery sometimes, and do some work that way. But the limiting factor usually is the commute. Before COVID certainly, and even now. So if somebody needs to get on the subway or a train, or that's always the limiting factor. Sometimes people can get a car service. I have a relative drive them, which facilitates going to work. And then we have, a lot of physicians that we operate on they're so, for some reason, physicians are highly motivated. They go to work like the next week, regardless. They push through it for some reason, which is quite amazing to see. And but the commute is really the limiting factor.
Sure.
There are very few people now who really do manual labor that would limit their ability to do things after spine surgery.
Both of you have a fair amount of athletes that come through your practice, or performers, dance performers and so forth. How about return to golf, return to sports, working out?
Yeah, I mean, my patients on the call here, they'll know that I always scare them off in terms of playing golf, because there's just so many data showing that people who play golf have higher complication rates after surgery, after back surgery, especially back surgery. So golf, I usually tell patients 3 to 6 months after surgery, and that has nothing to do with ambulatory versus inpatient surgery. I would tell every patient the same, because I don't think the fact that you do it in an ambulatory setting really affects the ability to go back to golf.
I think the thing that might be different is that if you're doing a type of surgery that is able to be done on an ambulatory basis using these minimally invasive techniques, it's more likely that the athlete is going to be able to get back from a pain standpoint and from a function standpoint to where they were before the surgery or before their injury than they would if they were having to undergo some of these more traditional open techniques like we see in the pictures here on the left. That's just a typical laminectomy that would have been done using traditional techniques. You can see we've got to expose all of the bone. We have to strip off all the muscles from the bone. And it's a pretty extensive and morbid operation. Even though that's a pretty straightforward and simple type of a spine surgery to do, and now we can do it through a tube or through an endoscope with way less muscle disruption, way less bony removal, smaller incisions. So they might not be able to return to sport any quicker, but they'll probably have a higher likelihood of being able to return to the same level of performance than they would with one of these traditional techniques.
Sure. Well, let's walk me through this, how things have changed. I guess this is what you were talking about, just the number of surgeries growing in this particular field.
Exactly. This is just an example of the trend towards being able to do things on an ambulatory basis. So as recently as 2004, even the most basic, straightforward surgeries that we would almost always send home on same day now were being kept in the hospital, were being done on an inpatient basis 80% of the time. And that number has changed to the point where now those patients are being able to go home the same day 80% of the time. And that is because of people like Dr. Hartl, who have pioneered back in the 2000s these minimally invasive techniques that have driven this ability to send patients home sooner, or for patients to be able to go home sooner. They feel comfortable going home sooner than they did, even as recently as the early 2010s. You can see the trend continues to go up.
Yeah, I had a question. What about COVID? Like maybe that's interesting. Somebody's asking a question about COVID and rehab, but what about COVID and ambulatory surgery versus? Is there any thoughts about that?
Well, as you guys know, when New York City shut down, all elective surgery came to a halt, and it was because we needed every single resource, including hospital beds, in the hospital. And many people did not know that operating rooms were being converted to ICU beds because of how much demand there was need for helping people. As things started to improve, the operating rooms started to open up again, but mainly the ones in the surgery centers that were sort of not connected to the hospital directly. And the surgeries that were allowed to start first were the ambulatory ones that would not require ICUs or other hospital beds, because they, again, were all needed. And unfortunately, we're seeing this again with our colleagues down in Texas and Louisiana and Florida, where they're not allowed to do surgeries that require hospital stays or even surgeries at all. And then the second part of this is that the less you have to be admitted somewhere, the less chance you have of some sort of infection. I mean, we got to the point where COVID was no longer an issue in the hospital. So we don't want to make it sound like it's dangerous to be in the hospital. But there was a time where we didn't even have that option.
Right. Yeah, I mean, you have to kind of balance, I guess, the benefit and the risk. I think for the right procedure, I think doing this in the ambulatory setting has like a huge number of advantages, right? It's
Yes.
For the patient, if the patient has the right mindset, the right expectation, for the efficiency in an ambulatory center can be much higher, and it can be a more pleasant experience for a patient if they don't have to be overnight in a hospital, especially if they're maybe worried about things like COVID. Even though it is not a concern, I agree, but theoretically it could be. So that's the advantage of ambulatory surgery, I think.
I guess one thing we haven't talked about is what is the potential economic benefit? I mean, costs to the patients have got to be much lower as well, because hospitals, I always laugh when I had my children. It was probably the most expensive hotel room I've ever stayed in to do that. So, I mean, there's probably savings to the patient, saving to society, savings to, insurance costs. Have you guys ever looked at that?
Most expensive hotel and probably the worst hotel.
No, we're positive on our hospital. 14 South and all those beautiful spaces in NYP, Weill, Cornell, and in Queens.
Well, of course, if she was a patient at Cornell, but yeah, we definitely know that it's cheaper for everyone involved, for the insurance payer, for the patient, to undergo surgery in an ambulatory surgery setting, because there's just less resources that need to be compensated for, that need to be brought to bear on the process if you do it in an outpatient setting. So it's definitely cheaper. I'm not sure how much of that flows through to the patient, but I think the trend for things to take place on an outpatient or an ambulatory basis will over time decrease the cost of undergoing spine surgery for everybody. And so there are definitely economic benefits that accrue from this trend.
Sure. To answer a couple of questions in the chat, there was a question from Douglas about ablation, a good procedure for same-day surgery. So that's actually on the pain management side. And absolutely, it's always ambulatory. And in fact, it can be done in our office or in a surgery center. And then from Betty and Ira, is ambulatory surgery available in Queens? Well, you're looking at the man himself leading the way in Queens for ambulatory surgery, Dr. McGrath.
Absolutely, it is. Absolutely, it is.
So walk me through some of the pictures. What are we looking at here?
Well, I think it helps from the patient standpoint, just to see what we mean by minimally invasive surgery, the types of things that have led to this trend towards patients going home the same day. And the two technologies that are visible in this series of pictures are intraoperative navigation. So we scan the patient in the OR, and we have a GPS system for our instruments that shows us exactly where all of the patient's anatomy is, using these little pointers and things like that. So we can make the smallest incision possible and be very precise in how we place all of our tools. You can see in the upper right picture, there's just the smallest little incision that we're making, just big enough to be able to pass these tubes through, to be able to go down and operate on where the problem is in the patient's back. So I think this just demonstrates nicely how small and how miniature all of the tools that we're using these days are. And I think it helps drive home why exactly things are so different than they were 10, 15 years ago in terms of the patient experience after surgery.
this gentleman doesn't look like either one of you. So,
One of the assistants.
okay. All right. I think we've talked about some of this, but one of the things at the bottom of this slide is biologics. What does that mean?
Yeah, Neil, I can say a few words on biologics. Now, these are three patients who we operated on here who went back to their activities very, very soon after surgery. And this is all, they know that their pictures are here, so they agree. The lady on the right side, she runs safaris in Africa. She's a travel agent. She's in her mid-70s now. She had surgery maybe about 10 years ago. She had a lumbar fusion. She was back in Africa a month after surgery running a safari, which was pretty amazing. And the other lady here in the middle is actually from Ecuador. She's a avid outdoor enthusiast, and she does these crazy. She had a cervical fusion. She had an ambulatory that was an ambulatory operation. And then the gentleman at the bottom here is a boxer who had a spinal tumor that we removed with minimally invasive surgery, who went back and became a world champion, a middleweight world champion, a year and a half after his surgery. So these are all examples of patients who were treated with less invasive, minimally invasive surgery. Some of these were done with ambulatory surgery. And these are just things that we're really proud of and that really have helped us over the years to really develop ambulatory and really facilitate ambulatory surgery, and it's because of those things that Lynn talked about, being able to do these surgeries through a tiny incision, very, very precise, no adverse side effects, do it repeatedly, and to really get good at this, and then you can do it in an ambulatory setting. So, but now I've almost forgot your questions. You want to talk about biologics. So biologics is really, in my opinion, is like the new frontier. And there has to be a lot of research really has to be done on biologics. But we're doing it. We're doing it in the lab. We do bench research on disc. It's primarily for discs, but it's also for example, for facet joint regeneration, but primarily for discs. So patients with degenerated discs in the neck or in the lumbar spine, we're studying how we can use the power of biologics, and usually the power of your own biologics. So your own stem cells, platelet-enriched plasma, for example, to treat pain syndromes associated with disc degeneration, and we're doing that successfully in patients, but we're also studying it prospectively in patients with and without surgery, to hopefully be able to introduce this into the spine center, and maybe even combine it with ambulatory surgeries in the future.
Great. Right. Related to what's here on the slide, somebody asked about, do you do more than one level lumbar fusions in ambulatory surgery?
Yeah, I put this slide together because we are talking a lot about the different types of surgery that we can do minimally invasively now. But what are the most common things that are done on an outpatient basis? And these are those things. So if you need a microdiscectomy, or a lumbar or a cervical laminectomy, a decompression, or an anterior cervical discectomy or infusion, if you need one of these types of surgeries, previously you were looking at a 1 to 3 day stay in most cases. Now, very commonly, you can expect to be able to go home on the same day if you want to. Multi-level fusions, we will still do those. Of course, it depends on the details and a person's particular case, but we will quite often do those using minimally invasive techniques. And if not being able to send someone home the same day, going home the next day is pretty typical in terms of a patient experience. Now, if you're going through a big scoliosis correction or a revision kind of a surgery, then probably that option is not going to be for you. There are limitations to what we can expect, and there are reasons why we would want to keep you in the hospital. So while the trend is towards these minimally invasive same-day operations, there are certainly times when it's not appropriate, and probably multi-level complicated fusions would fall into that category.
Great.
Yeah, I want. Yeah, this is going back to the biologics, that slide. But I had a comment on one of the comments here in the chat box.
Sure.
These are all excellent comments, by the way. Somebody's asking how many percent of surgeries that later need fusion. You know, that's very difficult to say. It depends on the type of surgery that patient had in the first place. But just to show you the advantage of minimally invasive surgery, we published a paper maybe about 5 years ago comparing patients, and that was based on was a meta-analysis based on published literature, comparing surgery for a patient who had lumbar stenosis in the lumbar spine, so severe nerve compression in the lumbar spine, patients who had that surgery done with open traditional surgery compared to patients who had minimally invasive decompression done for this particular problem. And in the group that had open surgery, 15% required a fusion later on. In the group that had the operation done with minimally invasive surgery, only 3%. So it just shows, and this is relatively good scientific evidence from the literature showing that the type of surgery matters. And if you do open surgery, there are more patients that are going to need fusion surgery potentially later on than if you do the surgery initially with a minimally invasive approach. So I have that paper, I show it to patients sometimes, and it really shows you the power of minimally invasive surgery. And then if you can do that minimally invasive surgery in an ambulatory setting where the patient goes home the same day, even better, So it's really changed.
Great. Your new book came up here.
Yeah, so that's just a reminder on biologics. Again, we're doing a study now where we include patients who have that interest, patients who have lumbar disc herniation with radicular pain. We do the operation, minimally invasive, ambulatory. These patients go home the same day, but then we offer those patients at the same time to repair the disc with stem cells that we harvest from those patients' iliac crest at the same time. So that's one of our first kind of explorations in the clinical setting of using stem cells actually in the operating room. I mean, you guys, Neel and Ricky, you use stem cells percutaneously through needles in the spine center, but very, very few surgeons really have used it in the operating room. So we're actually the first ones now who start using stem cells for spine surgery in the operating room, not only to take the pressure off the nerves, but then also to regenerate and repair the disc, hoping that this will avoid the need of more future surgery and future fusion surgery.
So one of the questions that just came up, can the minimally invasive surgery be done without general anesthesia? And I guess that's a great question for all, you guys and for me being once a practicing anesthesiologist.
I think maybe Lynn can say a few words. Also, Lynn, you got to know he was trained in endoscopic surgery, which is really one of the frontiers of minimally invasive surgery. And I'm not sure if that's something that you're going to do in Queens, but that also goes in that because a lot of endoscopic surgery is done with local anesthetic, right? Maybe you want to say a few words about this.
Exactly. Yeah. One of the benefits is that you can do these surgeries awake. And I've done endoscopic surgery on patients that are awake, and it goes very well. People seem to like it, especially as we get more and more experience, especially from the orthopedic world, doing hip replacements and knee replacements under spinal anesthesia where the patient is awake or they're just, mildly sedated through the surgery. Those are much more invasive, much more morbid and painful surgeries than an endoscopic or even a minimally invasive, disc resection or laminectomy. So it's definitely an option. It's mainly driven, I think, by patient demand. There's a lot of patients that just don't like the idea of being awake for their surgery. They just want to be out for it. And that's totally reasonable. And it's so safe. that we continue to offer that option, even if it's safe to do it awake. Some patients definitely want to be awake, and that's something that we can do pretty easily. I think one group that this opens spine surgery up to that may not have had many options in the past are elderly patients and frail patients who stand to have to risk more undergoing general anesthesia. When the risks of undergoing general anesthesia are too high, spinal anesthesia, I think, can be a good option and a way to get relief to people who aren't really robust enough or have some kind of a contraindication to undergoing general anesthesia. So that option is there. Most people want to be out for the surgery, but it's a great option for people that are comfortable with it and they like the idea, or who really can't withstand general anesthesia.
Yeah, Roger, I think you've sent me a couple of patients that had stenosis, and we did some other procedures, not quite surgery, but folks that had Alzheimer's, dementia, where general anesthesia could be risky, or they had severe heart conditions. And we did things like the mild procedure or a spacer in between bones as a compromise, for those that couldn't go the traditional route. So yeah, I mean, as you can see, the options are opening up for people there. Couple of questions as we're getting close to ending. Is there a clinical trial regarding the biologics? I guess for you, Roger. You're on mute, my friend. Yeah, there you go.
I couldn't unmute myself, which is, stem cells are not covered by insurance. That trial that I mentioned in patients, that's something we actually offer at no cost because we're collecting data on that. But otherwise, you can also, if you're not part of the trial, you would have to pay for that, and it's not cheap depending on where you go. But if it's part of a trial, we don't charge patients for that. There were a few other questions about XLIF. So XLIF is the lateral fusion procedure. That's not being done under, I don't know, was it ambulatory or was it done?
I think there was a question about ambulatory.
Ambulatory. No, because some surgeons do it, but there's a risk of injury to the blood vessels during that operation, which is very, very low. But it's not a risk that you want to take if you can do that operation in a hospital where if God forbid it would happen, where you would have all the resources to deal with a complication like that.
Sure.
So, and then one patient asked about the why was minimally invasive not recommended. It depends on the type of surgical problem that there is or diagnosis. Something to discuss with your surgeon. I'm sure there was a reason for that.
One of the latest questions, and timely on this slide, as I mentioned, we welcome seeing you, and to make an appointment, we've posted the number here. So for you, Mr. Kapu, certainly we'd be happy to see you. I think somebody talked about how to become part of the trial. Well, that's obviously if you're a surgical candidate. And why no comment on thoracic ambulatory surgery?
I think we haven't really commented much on thoracic ambulatory surgery because those operations are just much less common. The thoracic spine is less prone to having disc herniations or stenosis. It's less prone to having problems. And so it's just a less common operation. But I actually, I know that Dr. Hartl recently did a patient with a thoracic problem on an ambulatory basis. So it certainly can be done. It's just less common, and so it applies to less patients.
Sure. Well, we have reached our time, and as always, we have a lot of fun interacting with our audience. And really, we did this during the height of COVID because we didn't have much else going on, and we're still continuing because we enjoy it so much. And every time I find such great questions coming, I want to thank my two colleagues here, Dr. Lynn McGrath, again from NYP Queens, and world famous Dr. Roger Hartl, who is, once again blessing us with his knowledge and experience. We invite you to watch our previous episodes on YouTube that are listed here, and this is every 2 weeks. So hope to see you on the next one.
Thank you, Neel.
Good night.
Thanks, everybody.
Good
Fun
night.
to be with you.